Okay, so what we're looking at here is a uterus. There are white nodules, those are fibroids. They are typically benign, common tumors. You notice they're encapsulated. There's um, microscopic similarity to normal smooth muscle tissue. So this is a leiomyoma. Benign mild anaplasia. Here we have normal. And look at the stromal here. So these are neoplastic glands, but yet they still resemble normal endothelial glands to some degree. But if you compare them to normal, you can see that there's a difference. They're larger, they're arranged not as evenly, they don't share the same cellular architecture. The pinker glands are neoplastic. They still, however, look similar. Here's cancer with moderate anaplasia. Squamous cell cancer. These are neoplastic squamous cells. They make abundant keratin. These are the arrows. We call these the keratin pearls. Here you have normal skin. Juxtapose this, you see these keratin pearls here, which is considered squamous. The cancer is more disorganized than the left, but still making keratin. Those are the pink whorls. So squamous cell has keratin pearls. This is severe anaplasia. Take a look at normal. This is breast cancer. There's no gland formation. We can't even recognize the breast histology here. There are no glands, only solid cords of cells. It's like a massive flood infiltrating the tissue. So severe anaplasia or disorganized cellular structure. Again, severe, here's our normal. This is the colon. There's sheets of unrecognizable cells that don't even look like epithelium. No resemblance at all. So look at the demarcation of normal epithelium, and here's no resemblance. Anaplasia has abnormal nuclei. There's a high ratio of nucleus to cytoplasm. Nuclear hypochromasia, it's a darker color. They're clumped chromatin, prominent nuclei. The first impression under a microscope is blueness. And usually that's obviously a bad sign because high mitotic turnover, higher than normal cellular rate, is usually what will cause metastasis. Other nuclear features of anaplasia of pleomorphism. In normal tissues, the cells are relatively uniform. In pleomorphic states, there's variation in size and shape, nuclear and cytoplasmic. There's tumor giant cells and frequently and sometimes abnormal mitoses. Mild anaplasia. If we look at the nuclei, here's our normal colon. Notice how dark this is. The resemblance, blue. Remember, blue is bad. This is an adenoma. Severe anaplasia, let's look at the nuclei. The cell is dividing 3 ways. This is almost always a sign of malignancy. In nuclear pleomorphism, tumors give us giant cells and tripolar mitoses. So you may see 3 nuclei. So histological diagnosis of malignancy, no particular single parameter. Then metastasis, which usually allows recognition of a malignant neoplasm microscopically. However, in the presence of severe anaplasia, the pattern of invasiveness is generally the criteria which is most useful for diagnosing. So if we look at the neoplasm spectrum, we go benign, intermediate, and malignant. So take a look, which of these is malignant? You see this white stellate scar. It's not it's spreading out. It's got fingers, where this looks more encapsulated. This is malignant with infiltrative borders, and this is benign, pushing the borders. Which looks malignant to you? Well, let's take a look. Disorganized versus organized. This is benign, no anaplasia. Here we have severe anaplasia. It's disorganized, right? Pushing borders, split, multiply mitoses. So how do we name them? This is where we get into nomenclature. So before we launch into that, give you a little bit of intro to nomenclature. Carcinoma implies epithelial origin. So a sarcoma denotes mesenchymal origin. Both terms generally imply malignancy. So carcinoma, sarcoma, malignant. Benign, as we covered here, are usually well differentiated. They have low mitoses or mitotic activity, usually no metastasis or necrosis. We said malignant tumors or cancers show poor differentiation, erratic growth, local invasion, and decreased apoptosis. And apoptosis is the body's normal way of getting rid of old cells. We need apoptosis. Every month that a woman menstruates, if she doesn't become pregnant and there's no implantation of an embryo, then normal apoptosis takes place and the endometrium sloughs off and she menstruates. Similarly, we have normal apoptosis in the healing of a scar. So apoptosis is important to protect our body when there's no organized apoptosis, and apoptosis is off the table, usually due to some type of proto-oncogene, either taking a tumor suppressor gene and shutting it off, or igniting one that is able to cause multiple mitoses. We don't get apoptosis, which is bad. So when we take a look at different types of cancer nomenclature, and we look at the epithelium, right, which is the surface, but epithelial layers, a little bit higher up on the in the layers of our body and of our skin, we refer to adenoma or papilloma. If it's benign, if it's malignant, we basically call it an adenocarcinoma or papillary carcinoma. Your mesenchymal tissues include blood cells, blood vessels, smooth muscle, striated muscle, connective tissue, bone, fat, and melanocytes. So in blood cells, there is no benign. It would become malignant, causing leukemia or lymphoma. In blood vessels, it would be a hemangioma. That if it's benign, it'd be a hemangioma. If it's malignant, it's an angiosarcoma. If it's smooth muscle, you have a leiomyoma, which we just looked at earlier in one of the lectures. If it's malignant, it's a leiomyoma sarcoma. Striated muscle, rhabdomyoma, or rhabdomyoma. Malignant, rhabdomyosarcoma. You see, the sarcoma is where you want to focus. Connective tissue, fibroma. Malignant, fibrosarcoma. Bone, osteoma. Malignant, osteosarcoma. Fat, lipoma. Malignant, liposarcoma. A melanocyte, that makes our skin give its color. A nevus or mole. Malignant, melanoma. Okay, let's continue laying that foundation. So nomenclature's neoplasms are composed of proliferating neoplastic cells, but also contain non-neoplastic supportive stroma of connective tissue and blood vessels. Ignore the supporting stroma, only look at the clonality of the neoplastic cells for nomenclature. So tumors are named according to their neoplastic component: cell type, epithelial, mesenchymal, the modifier to indicate whether it's benign or malignant, and the site of origin, bone, osteo, right? As an example. Benign tumors are often designated by the suffix "oma," and the prefix designates the cell of origin. All right, now we jump into this. Benign mesenchymal neoplasms, and I just went over what a mesenchymal is. Cell type fat, benign lipoma, smooth muscle, leiomyoma, skeletal muscle, rhabdomyoma, fibrous tissue, fibroma, blood vessel, hemangioma, cartilage, chondroma. I hope it's starting to make a little sense now. Benign epithelial neoplasms. Typically, an adenoma is a benign neoplasm derived from glandular epithelium. A cystadenoma is benign epithelial neoplasm with cystic or fluid-filled cavity, whereas a papilloma is a benign epithelial neoplasm producing finger-like or papillary projections. Think of them like sea anemones. The papillary growth pattern typically within a cyst, but not always. Bladder tumors are a common example. So, have that. Interior of a tumor, a papillary growth inside of a cyst. So papilloma, you can see little fingers growing in the cyst. They look like pearls almost. Then add the site of origin. Examples of benign neoplasms: leiomyoma of the uterus, chondroma of the femur, adenoma of the colon, cystoadenoma of the ovary, papilloma of the larynx. Malignant neoplasms, here we go. Carcinoma arises from epithelial tissue. Adenocarcinoma arises from glandular epithelium. And sarcomas arise from all the mesenchymal tissues that I had mentioned beforehand. Malignant neoplasm nomenclature continued. A lymphoma arises from lymphoid tissue, and leukemia arises from blood or bone marrow elements. So you want to think of your hematopoietic system, right? Your hematopoietic system makes a lot, doesn't it? It makes your T cells, it makes your B cells, it makes all your white cells, it makes your red blood cells. Any of those can become malignant. Then add the site of origin. Examples of malignant neoplasms: leiomyoma sarcoma of the uterus, chondrosarcoma of the femur, adenocarcinoma of the colon, squamous cell carcinoma of the larynx. Here's our nomenclature. Origin, we have fibroblasts, we have glands, we have smooth muscle, we have squamous. Fibroblasts, benign fibroma, malignant fibrosarcoma, glands, benign adenoma, malignant adenocarcinoma. Origin, smooth muscle, benign leiomyoma, malignant leiomyoma sarcoma. Squamous, squamous papilloma, malignant squamous cell carcinoma. Remember, they have the keratin pearls. Again, we take a look. Lymphocytes are benign. No real benign tumor, because once the lymphocytes proliferate, they go everywhere, so it's always malignant. Lymphoma. Granulocytes, again, not benign, because granulocytes are made through our hematopoietic system within our bone marrow. They become malignant, we get leukemia. There are 3 germ cell layers: benign teratoma, malignant teratoma carcinoma. The GI wall, we have GI stromal tumor, and Malignant is GI stromal tumor. It occurs in the walls of the GI tract. These are rare. They usually have the same name with benign or malignant added. Um, so that's kind of unusual, but that's the terminology. Leave it to the pathologists. Exceptions. Many omas are malignant. A lymphoma, a hepatoma, liver cells, seminoma, the seminiferous tubules, melanoma, should be considered melanosarcoma, but they don't. It's a tumor of the melanocytes. And a lot of people that are out working in the sun quite a bit can get this. Let's take a look. Here's a tumor, the liver. How would you describe the liver? Look at the borders, irregular borders, nodules everywhere. Could be necrotic in the center. This could be from distant metastasis, possibly. A tumor of the liver, multiple mitoses. See how dark the nucleus is? So this is bad. This is the popcorn that I talked about. And wonder where it's coming from. Possibly the bile ducts. This is an adenocarcinoma of the bile duct with malignant features, infiltrative borders with many mitoses with gland formation, with glands forming neoplasm, aka cholangiocarcinoma. Here's a tumor of the adrenal gland. It's pretty big. How would you describe the borders? And the answer in 2 slides. Normal adrenal, minimal anaplasia that resemble a normal adrenal, right? Just looks like they're on steroids. This is an adenoma of the adrenal cortex. It has benign features. It's pushing the circumscribed borders. We don't see a lot of mitoses or anaplasia. Is the adrenal gland an epithelial structure? No, historically they called it this though. It's a neuroendocrine, actually, epithelial. Grade. Okay. Grading is a histological parameter quantifying the degree of differentiation of the cancer cell. So capture the anaplasticity of the tumor. A grade is the way to describe or quantify how bad or anaplastic the tumor cells are, or how much from normal they differ, if that makes sense. Differentiation. Well differentiated is a low grade. Tumors resemble the mature normal cells of tissue of origin, not as much anaplasia. Poorly differentiated is typically high grade. They show little resemblance to the tissue of origin, usually higher mitoses of the nucleus and a higher nuclear to cytoplasmic ratio. We grade tumors according to 3-tiered scheme, well, moderately, and poorly differentiated. And the grading systems vary by the type of tumor. The importance of grade. Many tumors show a range of differentiation from low grade to high grade, and for those that do, grade will predict behavior for many common malignancies. So grade and prognosis. Grade 1, we have a 95% survival rate. Grade 2, moderate anaplasia, 75%. Grade 3, 50%, and that's because it not only pushed the borders, but went through the borders, the basement membrane, and probably spread hematogenously. The grading of cancer has limitations because many tumors are of intermediate differentiation, all in one site, such as colon cancer. So we sample with error, there's sampling error with small biopsies. Grading is based on subjective light microscopy interpretation. So observer variation and error may be taken into account for the person who's looking at it. So factors that would influence whether surgical resection would be curative is whether, of course, it's benign or malignant, the location, the cell type, of the neoplasm, the degree of anaplasia, and all of the above. Of course, all of the above. And the end. Hopefully, you've enjoyed this. You have a little bit of understanding now of medical terminology when we talk about neoplasia, we talk about grading, we talk about the different types of cancer, leiomyoma, leiomyoma sarcoma, right? Um, and yeah, so keep studying. I hope you enjoy these. Hope you enjoy these lectures. Bye.